One of the most promising frontiers in regenerative medicine is the possibility of slowing or even preventing spinal degeneration, not by waiting for damage to accumulate, but by intervening at the cellular level before symptoms appear. The spine, like many structures in the body, ages slowly and silently. Early in life, its intervertebral discs are flexible, well hydrated, and rich in collagen and proteoglycans. But by middle age, many people begin to show radiographic signs of disc thinning, reduced hydration, or subtle bulging, even without back pain. What's become increasingly clear is that senescent cells, or aging zombie cells, may play a critical role in initiating this downward spiral. And this insight raises an intriguing question. Could senolytic therapy, if started early, serve not just as a treatment, but as a true preventive strategy for spinal degeneration? Cellular senescence is a biological process in which damaged or stressed cells permanently exit the cell cycle but resist death. Rather than disappearing, these cells linger in tissues and secrete a pro-inflammatory mix of cytokines, chemokines, proteases, and growth factors known as the senescence-associated secretory phenotype, SASP. In small amounts and in short bursts, this response can be beneficial. It helps coordinate tissue repair and suppress tumor formation. But when senescent cells accumulate chronically, especially in long-lived tissues like the spine, they contribute to inflammation, structural breakdown, and impaired regeneration. The intervertebral discs, which serve as shock absorbers between vertebrae, are particularly vulnerable. They are avascular, meaning they receive minimal direct blood supply and therefore have limited capacity to flush out cellular waste or mount large-scale regenerative responses. Studies have shown that even in relatively young individuals, mechanical stress, oxidative damage, and metabolic changes can trigger premature senescence in disc cells, particularly the nucleus pulposus cells responsible for maintaining disc hydration and flexibility. These senescent cells then release SASP factors that degrade the disc matrix, attract immune cells, and trigger further stress responses in neighboring healthy cells. This creates a feed-forward loop that quietly weakens the disc structure long before overt symptoms like pain or stiffness develop. The appeal of early senolytic intervention lies in disrupting this loop before degeneration becomes clinically significant. By selectively clearing senescent cells from spinal tissues in middle-aged or at-risk individuals, we might preserve disc health for decades longer. Animal studies support this idea. In murine models, administration of senolytic compounds such as physodin, quercetin, or navitoclax has been shown to reduce senescent cell burden in spinal tissues, slow disc height loss, reduce inflammation, and improve spinal biomechanics. Crucially, these benefits are often observed even when senolytics are administered intermittently, underscoring their potential for long-term protective use. Preventive senolytic therapy may be especially useful in individuals with known risk factors for spine degeneration, those with a family history of early disc disease, occupations involving heavy lifting or prolonged sitting, metabolic disorders like diabetes, or systemic inflammation from obesity. In these populations, senescent cell accumulation may begin earlier and progress faster. The ability to prune senescent cells in a targeted way could serve as a maintenance strategy, similar to how we use statins to prevent heart disease or bisphosphonates to prevent bone loss. What sets senolytics apart from conventional anti-aging supplements or anti-inflammatory drugs is their mechanistic specificity. Rather than simply dampening inflammation, they aim to eliminate its source. And because senescent cells are non-dividing and often metabolically distinct, it's possible to target them without affecting healthy, proliferating cells, especially when treatment is delivered in periodic, low-frequency cycles. Of course, there are still challenges ahead. We don't yet know the ideal window for intervention. When exactly do senescent cells in the spine begin to accumulate at harmful levels? How often should senolytic therapy be administered to maintain disc health without disrupting necessary cellular processes? These are questions that ongoing human trials and biomarker development will help answer. Researchers are also working to develop non-invasive tools, like blood-based senescence biomarkers or advanced MRI techniques, to identify early cellular changes in spinal tissues before irreversible damage occurs. But even with these unknowns, the logic of prevention is compelling. Waiting for symptoms to appear often means structural damage has already occurred, and treatments become about managing loss, not restoring vitality. Senolytics offer a proactive approach. one that aligns with the growing field of geroscience, which aims to target the biological processes of aging rather than just its consequences. If future studies confirm what early research suggests, the aging spine may no longer be an inevitable source of pain and disability. Instead, it may become a prime candidate for longevity-oriented medicine, where cellular cleanup through senolytics helps preserve function, mobility, and independence well into advanced age. Rather than accepting spinal degeneration as a passive outcome of time, we may soon be able to actively shape its trajectory, starting not with surgery or physical therapy, but with a small, periodic dose of molecular housekeeping.